with patients and people in the oh, and a final thing I wanted to say is that, as I mentioned, we're a very ethnically diverse neighborhood, but it's also important to remember that many of our patients are younger, new to the country, and extremely hardworking. For instance, myself being in the breast clinic where most of my patients are women, many of my patients are in New York are housekeepers, nannies, carers of the elderly, construction workers. And as we who work here know, people who work hard like this, if they don't go to work, they don't get paid. So we have tried very hard at Elmhurst to help with that, you know, not to have a whole lot of unnecessary visits because so many people coming for a mammogram shouldn't take all day, kind of thing. And so we have also opened up primary care visits and mammography visits in the evenings during the week and also on Saturdays, which has hopefully made a big difference to get people, for at least for people who have Monday to Friday day jobs, to be able to come and get breast cancer screening. And then just a final thing that I remember seeing as I was reading about today's lecture and things is that in New York, it's quite, I think, quite normal, and especially at Elmhurst, that patients and providers alike at Elmhurst all have to wear a mask. So from the point of view of reminding patients coming for screening about staying safe, we do all have to wear a mask. I think the final thing I wanted to say about breast cancer screening was more so, what is screening? For sure, a lot of people have heard of mammography, which is a big part of it. But I think it's important to remember that screening for breast cancer is maybe more than just that test. Screening for breast cancer, I think to a large degree also involves a visit with the primary care doctor. So most certainly, like in Elmhurst, getting women to come back to see their primary care doctor after COVID and things, or in general, is very important. Women, like all of us, generally have a good sense of what is normal, like know your normal type of thing. How does my body feel? Is it different? Are things normal? And so at a primary care visit, for instance, if a woman felt that an area of the breast didn't feel normal anymore, it would be important to point that out to the primary care doctor, which sometimes the doctor or nurse practitioner or the provider may not always appreciate. So this first part of the visit, which is getting the history and talking, I think is very important. And another part of this part of the visit where the provider and the patient are talking that I think is very important also is remembering the family history. Many women don't indeed have a family history and are oftentimes the first women in their family with breast cancer, but women who do have a family history, I think it's important for the provider to remember to ask about it, and for women to, if they should forget to ask about it, for a woman to potentially remember to mention it. A sister or a mother with breast cancer, or aunts, cousins, grandmothers, it's all very important to know about. And especially if any of these relatives are younger, which generally means younger than 50, is something to think about. For instance, as an example, if a woman came in and said that her mother had had breast cancer at 45, we say that women should start screening for breast cancer 10 years before the age of their first degree relative, like a sister or a mother. And so they might potentially, like in this case, start screening at 35, which could be younger than the average woman might start. So I think talking to the provider and the patient talking is important as well for screening. The other part of a visit should, of course, include having an examination, being examined. When the breast is examined, we always examine the lymph nodes in the neck and the armpit to check that they are not swollen. And then, of course, an exam of the breast to feel for any lumps or bumps is very important. And then, of course, I think most people know about mammography, but a regular mammogram is most certainly a huge part of screening. And as you've already mentioned, reminding women after the pandemic to come back to screening in various different ways and having a mammogram regularly, I think we can all agree is very important. Thank you.
Thanks, Dr. Pocock. You really were speaking to my health equity heart because we're here talking about empowering women, but we're also, what you mentioned was really also adjusting the system, like, disrupting the system really to make sure that we're meeting the needs of the patient, having a patient-centered understanding, giving them education and the empowerment, but then also teaching clinicians how to talk to patients in a way that's individualistic and responds to what they know and what their health history is, but then also saying screening looks different for, everyone. It's not just may not be just that one appointment. It might need to be follow-up visits. They might need to be tailored to your language, to your culture, and they will need to be tailored to you. So I think that's a really important part of this conversation.
Yeah, you're absolutely right.
So we want to hear more from you all about, we're talking about how we're getting patients back into cancer screening. So our next poll, not just, thinking about you as an individual, but just in general, how can clinicians help patients get back into breast cancer screening? Your options are: 1, ensure that everyone in the practice is wearing a mask; 2, provide education and a reminder at each appointment on breast cancer screening; or 3, provide email reminders to return to breast health screenings. I'll give you a few moments to answer that poll. Okay, let's launch the results of this next poll. Okay, it looks like almost everyone said that providing education and reminder at each appointment is really important. And I guess we were able to pick more than one, but almost everyone said that was the most important. And then also ensuring that everyone in the practice is wearing a mask. About half people said that. And a quarter of people said provide email reminders to return to breast health screening. So thank you for participating in that. Our next question, we're thinking about still having reservations. We're still in the middle of this pandemic and some people still have reservations. And again, rightfully so. If you're still having reservations about returning to breast health screening, or if you know someone who is still having breast health screening reservations, think about this next poll to think about why you may or may not feel comfortable. The first option is that my doctors and their office staff do not wear masks, and I'm afraid of getting COVID-19. 2, I'm simply afraid of getting COVID-19 even with all the clinical staff wearing masks. 3, the COVID-19 pandemic has eroded my trust in the medical healthcare system. And 4, I simply don't know where to start. I'll give you a few moments to answer that. Okay, can we launch the results for this poll? Okay, we're really split on this one, which is fascinating. About 17% said that the concern about the office staff and doctors not wearing masks. About a third simply afraid of getting COVID-19. A third, just this trust issue with COVID-19 has eroded our trust in the healthcare system and medical facilities and medical healthcare providers. And then a few of us also simply just don't know where to start. And so I'm really interested to hear from this next group of people. We're hearing from survivors today, 2 survivors that might be able to speak a little bit more to this. Our first one is Angela Agogo, who's a laboratory scientist and supervisor of a chemical plant In December 2017, she was diagnosed with late stage 2 invasive ductal carcinoma and has received aggressive treatment and 6 different surgeries. Angela is proudly in the survivorship phase of her journey. And the second survivor we have is Lyndsay Levingston. Lyndsay is a multimedia personality and communications professional who has worked as an anchor, host, reporter, and producer in New York City, Houston, and Tulsa. She was diagnosed with stage 2B triple negative breast cancer in July 2019. Since that diagnosis, she shared her story with Essence.com, NBC News, Revolt TV, and Oprah Magazine, and she founded the nonprofit, her nonprofit, SurviveHer, to inform, inspire, and empower women. So welcome to both of you, and we're excited to hear what you're sharing with us today.
I'll go ahead and start. So like she introduced, my name is Angela Agogo. So my breast cancer story, as she said, December 2017. At the time, I was teaching anatomy at a nursing university. So each semester we give a lesson on self-breast examination. So it wasn't something that I wasn't familiar with. Originally, I noticed I was having some like small chest pain. It was like tingly feeling every now and then. Then it became more consistent. Then I started noticing, I guess whenever I was feeling around lumps, they were undefined. And at the time I did gain some weight. So I took it more as is just maybe extra breast tissue since I had gained the weight. But once the lumps started getting more defined in shape, started getting more firm, I knew. So I immediately went to the doctor for examination, and the mammogram found 3 lumps. One of them traveled to the lymph nodes in my armpit. The other one was benign. It was in my breast. And then one of them, sorry, I take that back. One of them was inconclusive. One of them was positive, BRCA2 for invasive ductal carcinoma. They did a biopsy, and so that's how they found out. And I mean, obviously I was very shocked at the time because I didn't have any family history of any type of cancer. So luckily my medical team was very supportive. They even recommended that I go and get genetic testing. And that's how I found out that I had the BRCA1 gene that was mutated. Now that I'm in a phase of survivorship, I do still keep in contact with my medical team. They constantly advocate for me. I was with my oncologist. When I met my oncologist, she initially was the one who told me that unfortunately there is a lack of support for women of color when it comes to cancer treatment. And she was one of the main people that told me, even after treatment, that patient engagement with your clinician is very important in terms of healthy survivorship. You're not just wanting to prevent cancer reoccurrence, but you're also trying to monitor and maintain your health beyond the cancer treatment, post I guess treatment. In terms of the pandemic, medical masks have always been proven, we all know, to be effective in terms of blocking disease transmission. My cancer center specifically was very small. So even before the pandemic, there was the mask requirement, especially in the actual chemotherapy room. Before we walked in, we had to wash our hands. We had to obviously get blood work done and things like that, but it was not just the patients, it was the advocates that would come in as well as the medical staff. So once the pandemic hit, it was even more in terms of, we were getting temperature checks and whatnot. So, and one of the requirements to even be treated was that we had to be vaccinated. Not that that was the reason that I got vaccinated, but it was communicated to us very early before the pandemic, the importance of vaccinations as well as the mask mandate, because as you know, chemotherapy can weaken your immune system and basically make you more likely to get an infection. So that's my story.
Thank you, Angela.
Good afternoon to everyone. I found that, as I'm listening to your story, Angela, that we have some parallelisms. So in July 2019, I was working in New York City in TV news, and during a routine self-exam in the shower, I felt a lump in my right breast. And I didn't think much of it, but I will say that it was tender and palpable. And so I immediately scheduled a well woman exam, and my OB-GYN scheduled what would be my very first mammogram at the age of 37. Because I have dense breast tissue, I then had subsequent exams. So 3D mammogram, breast ultrasound, an MRI, and a biopsy confirmed the lump that I felt during a self-exam was cancerous. So I relocated back home to Houston, which is where I reside now, to begin treatment. Officially diagnosed with triple negative breast cancer, stage 2B. So that requires a more aggressive form of treatment. The initial plan that was laid out by my breast surgeon and an oncologist as they worked in tandem would be 15 rounds of chemotherapy, neoadjuvant chemotherapy to shrink the mass, a lumpectomy, and 6 weeks of radiation. So I started my chemotherapy treatment. Between rounds 4 and 5, I received a call from a female cousin on the paternal side of my family, alerting me to the fact that breast cancer runs wild on the my dad's side of the family. I had no idea. Because of course, upon being diagnosed, my breast surgeon asked if I had any family history. Well, I didn't know that I did. So we proceeded, as such. So I took a genetic test, and that confirmed that I, too, Angela, am the carrier of the BRCA1 gene mutation. So I completed my chemotherapy treatment, rang the bell, and then I proceeded with the bilateral breast mastectomy as recommended by my breast surgeon, breast reconstruction, and an additional procedure, which happened right when COVID was starting, a salpingo-oophorectomy to remove my ovaries and fallopian tubes to reduce my risk of ovarian cancer. And so COVID happened, and then I had to schedule that surgery. And I will share this, my surgeon had to get special permission from a surgical board just to perform this, what was not necessarily medically necessary surgery. It was considered more, I wouldn't say cosmetic, but it was not medically necessary at the time when hospital rooms, ERs, operating rooms were really, shut down due to COVID. But we were able to proceed with the procedure. And I also had to undergo several COVID tests and rounds in and out of the doctor's offices while I was going for follow-ups and follow-up visits. And still to this day, I have appointments with my oncologist and breast surgeon, my quarterly appointments this Friday, and our offices here are still in mask. And so that does make me feel comfortable. But I will say this, I'll share this with any woman who is hesitant or fearful of going to the doctor at this phase in our, post-pandemic era. Don't be fearful, because if it could be the difference between life or death, right? If you prolong that critical life-saving exam, that mammogram, it could mean it could be really, I always like to say, life or death. Early prevention saved my life, and I'm so glad that I took the necessary measures when I did. But the COVID protocols now, or in our post-pandemic era, should not deter women, especially women of color, from getting those much needed critical preventative exams. Thank you for the platform to share my story of survivorship.
Thank you both for sharing your story. I heard a lot of things. One, just talking about the importance of all the prevention methods that we all know that we've been even doing prior to the pandemic. Angela talked about, masking prior and vaccinations prior. That's been important, and we know that in public health and in the healthcare world. but that being just even more critical now as we're living in this new normal where COVID-19 is a part of our everyday life. And then Lyndsay talking about just being empowered to advocate for yourself, knowing what's normal for you and making sure that you're advocating with your healthcare providers and not being afraid, even in this new normal, to make sure that you're checking on your breast health. So thank you both for sharing your stories. We have a few more polls before we kind of round out this conversation. The next poll, we want to ask you questions about your comfort level, either as a result of hearing from our panel today or just in general, whether you're talking about yourself or sending someone you love to return to regular breast health screenings. So 1, do you feel, yes, more confident? 2, no, you do not feel confident. And 3, I'm on the verge of confidence, but need more information. I'll give you a few moments to complete that. Okay, let's see what everyone is saying. Let's launch the results. Yay, almost everyone feels more confident. That's awesome. 92% said, yes, I feel more confident. And it's okay to not feel more confident. We have a lot of work to do in this space. So we definitely would like to know more about that if you feel comfortable sharing about what might make you feel more confident, either in the chat box, or if you have a question, you can put it in the Q&A box as we've been doing throughout. Their next poll question is just thinking about this whole presentation in general and how important it is to share just far and wide the message that we've heard today. So just simply, do you feel comfortable sharing this information with others in your peer and social support circles? This will be on the National Minority Quality Forum's YouTube page, and so you'll have an opportunity to share. So we just simply want to know yes or no if you feel comfortable sharing that, and I'll give you a few seconds to complete that. And we can launch the results now. Awesome, everyone feels comfortable. So yes, share. That will be on the YouTube page for you to share once the recording is available. So now we're ready to move to the Q&A portion of our webinar today. I'm not seeing any questions in the Q&A box. Kristen, let me know if I'm missing something. And I'll check the chat really quickly, but feel free to continue to put questions if you have any in that Q&A box or in the chat.
I don't see any questions either. Just some really, really supportive comments in our chat box with people thanking you guys for joining us. We do have an opportunity to answer questions afterwards. If you email us I will put it in the chat at shc@nmqf.org. Our team can get answers for you if you have any that you are not comfortable sharing today. So I think we can give, unless there's one. Go ahead, Stephanie, there's one. Answer that one.
So our one attendee asked, how can you empower other women to speak up and ask for further evaluation or testing if they feel their healthcare provider is not taking their concerns seriously? I don't know. I mean, I'm going to pitch that to the panel. I have thoughts, but I want to let the panel first answer.
So I am a part of a cancer support group. And although that wasn't my experience, I did have a few friends where that was their experience, which is very unfortunate. Majority of them just went and got a second opinion, or they even requested from the social worker if they could get a new oncologist, because obviously this is something not to be played with. This is something to be taken seriously. This is a sensitive subject. So if you're feeling dismissed or you're feeling like you're not being heard, I don't want to say it's a waste of time but this is a matter like Lyndsay said, this is a matter of life or death. And so that's something not to be played with, but at the same time, it's something to be taken seriously. So this is going to be the one time where if you're not confrontational, this is going to be the one time you're going to have to step outside of your box and advocate for yourself, because I'm not saying all clinicians, but there are some clinicians out there where you're just a number. And unfortunately, that's very unfortunate. So you will have to advocate for yourself sometimes.
Any other thoughts from panelists? I like to elevate the voices of survivors. One survivor told me one time, this individual thinks of her healthcare providers and everyone that encounters her in her care as her team. And so, you know, if you're on a basketball team and one player is not up to par, you counsel them and you coach them, you tell them what you need. And if they're not able to do it, they get cut. And so, you know, not to be, you know, brutal, but like this is your team and it is life or death. And so you can have a conversation and tell them that's a part of advocating for more what you need. But if they're the weakest link, it's okay to cut them. They're working for you on your team. So I think that's really important.
I'd also like to add that there are organizations, both in-house in various hospitals or clinics and via organizations that do offer the support of a patient navigator to help women navigate this very challenging, what can be a very challenging healthcare system. So I would advise them to consider tapping the support of a patient navigator.
Agree with that. And in some places there are nurse navigators, same function, but helping people navigate this system that we have. The next question, in states where there is a lack of access to providers and even less access to screenings, how can we empower women to seek help and seek it regularly? So we're talking about those areas with, you know, health disparities where there's not a lot of access.
You know, unfortunately, there are areas in which women of color reside that are lacking the appropriate access and resources to get, maybe it's a mammogram. I would suggest to women if they would tap into their church communities or even a community center through it, or even the YMCA or YWCA, those kind of internal grassroots community organizations would be able to guide them and lead them to the mammogram. There are organizations like SurviveHer, for example, my nonprofit. We are hosting a breast cancer awareness event in the heart of Brooklyn next weekend, and we're partnering with another organization to offer free mammograms in the communities in which women don't have access to them. So I think it's just a matter of kind of plugging into those community and nonprofit resources that are there. They're there. You just have to really put your ear to the street and ask.
To piggyback on what Lyndsay said, there's also, and I didn't know this until I had to get screening, Planned Parenthood, I know at least the ones over here in Texas, they charge like $12 to go and get the wellness. And it was there where they confirmed that I needed to go and get a biopsy. They were the ones, they had a nurse practitioner there who got to link me with the oncologist I had. So it was something that I didn't even know Planned Parenthood offered. So like Lyndsay said, a lot of the times the resources there, it's just a matter of actually asking the questions and trying to find out where you can get those resources.
Thank you for that. Our next question, do you advise getting a test to see if you have the biomarker, even if you have no symptoms? Is that possible, or is it helpful to know beforehand if there is no family history?
As the carrier of the BRCA1 gene mutation, I would advise that every person, man or woman, seek a genetic test, and also or ask your nurse or healthcare provider, genetic counselor to order that genetic test for you. I think it's important that everyone knows your status, because I didn't know that I was born with it in my DNA. I was born this way, as Lady Gaga says. So I was born predisposed to both breast and ovarian cancer. So if you know in advance your health risk, you can take preventative measures, whether it's a bilateral mastectomy or a hysterectomy for women who could be at risk for ovarian cancer. I think it's just so important that everyone takes a genetic test. Some tests are covered through insurance. Some may, there may be a nominal fee for those out-of-pocket costs. But that is, part of my messaging is not only to get your mammogram, stay on top of your mammograms and your annual exams. Number two, get a genetic test to know your family history.
Yeah, I agree with that. The challenge, like you mentioned, Lyndsay, is the insurance coverage and the costs associated with it, which is not equitable across the board, which is kind of what we're talking about today. Dr. Pocock, did you want to add anything to that?
Most certainly, with certain types of family histories, I think that insurance will absolutely cover the testing. Like you said, it may be hard in all cases for insurance to pay for it, but most certainly if you have, unfortunately, if you develop breast cancer and are young, that is most certainly a situation to test. If you have a first-degree relative, sister, mother, daughter who gets breast cancer at a young or any age, most certainly a young age. If there's any male breast cancer in the history, in the family, if there's any ovarian cancer in the family, these are definitely situations that no one would question. There should be genetic testing, and it would get paid for it in that sense.
And I'll also add, just advocacy organizations also offer some support for that. So it's really important to connect, again, with those patient navigators, nurse navigators in your local community-based organizations to let you know where there are options for financial assistance for things like that. Any more from the panel? We have another question if there's nothing else on that one. Go ahead, Angela.
I just wanted to say, I didn't know that my insurance offered it. I got breast cancer at 28. So I was young, and I found out that, I didn't even find out, my oncologist found out that the insurance I had offered it. And because of my age, they tested myself as well as my entire family. I'm one of 7 kids, so that's a lot. They tested all of us and my parents because of our history. So some insurances do offer it for free, but if you don't ask, it's not like they go out of their way to tell you.
That self-advocacy, we keep hearing that in this whole conversation. Here's a question really related to health disparities, health equity. What is the best way for providers and clinicians to change systemic disparities or inequities with respect to women of color? Is change more likely to occur from patient-driven advocacy, internal advocacy, and education among providers or clinicians, or both?
I'll step in on that one. So it's all of the above. So when we talk about health disparities and health equity, one of the things that we really focus on at the National Minority Quality Forum is reducing patient risk. And so when you don't know what your insurance is able to provide for you, like Angela said, when you don't have the wherewithal or the access to get a mammogram because you don't have insurance, those things really affect the ways in which you are able to move through life, therefore increasing your risk of poor health outcomes. So when we talk about changing the ways in which a system interacts with women of color, with LGBTQIA patients, with patients living in rural areas, these systemic disparities have to be changed in and of upstream fashion. And by upstream, I mean really changing the system and disrupting the system, as Dr. McCoy said earlier. We call it reimagining the system, but it's all the same thing. Really trying to get the system to work differently, because right now it's actually working the way in which it was designed. And that is to exclude those of us who have been pushed to the margins of society. So it includes all of those things. Another thing that I will say about advocacy, both on a public policy standpoint and internal advocacy and education amongst providers, is that you really, really, really are your best advocate. I really like what Dr. McCoy said. If your team is not performing, they have to go, you know? And I think that really understanding where you stand and the power that you have to say, no, I want a second opinion. No, I want you to spend more time with me during this appointment. No, you're not just going to tell me it's nothing. You have that power. And you also have the power from a public policy standpoint to really be an advocate for yourself. Dr. McCoy also mentioned that leaning on your community-based organizations is a really good way to engage in policy advocacy and legislative advocacy when it comes to breast health policy, because the way in which we get a lot of these systemic changes is through legislation. Not all of them, but a lot of them. So that's my 2 cents.
We have a few more minutes for additional questions, or if the panelists have any closing thoughts.
I guess I just one last thing. Don't think that at a certain age is when you have to start caring about this, because you couldn't tell me in my late 20s that I never even thought of it. I thought, you know, after 45, 50, that's when I'm going to start caring about it. The #1 comment every time I told somebody was, oh, you're so young. Oh my gosh, I can't believe it. You're so young. I met girls that were as young as 18 with breast cancer in my group of friends. So yeah, I just, especially if you know you have family history of it. Yeah, that's my 2 cents. Just don't think age has anything to do with it.
Well, thank you for that closing remark. I think we can close on that end. I want to thank Dr. Pocock, Dr. McCoy, Lyndsay, and Angela for taking time to speak with all of us about your journeys, about your expertise, and about this important topic. And thank all of the participants for joining us. Have a good evening, everyone.
Thank you.